Well, good morning, everyone. It's really an honor and a privilege to be here and have the opportunity to give you some of my thoughts on myocardial imaging, tissue Doppler, and strain imaging. I want to thank Dr. Keene and Dr. Orajema for allowing me to continue to participate in this course. It's really a course I feel very emotionally attached to, and it's a privilege to be here. And I can tell you that if you listen to the lectures and review the materials, that I think you'll feel very confident and comfortable going into the examination. So for this talk, I have no relevant financial relationships with which to disclose. Now, by way of introduction, I show you this picture. And this is a picture of my little boy and I a number of years ago looking at a stress echocardiogram. And you see, my son, he's pointing out to me where he thinks he sees a wall motion abnormality. And I'm trying to explain to him that the study is in fact normal. And I think this really highlights one of the limitations in echocardiography, and that is that the determination of global and to a larger extent regional function is subjective and dependent upon expert visual analysis. And so at the end of the day, the report's likely going to reflect my interpretation of this study, as there's a perception in some places at least that I'm a more experienced echocardiographer than my little boy. But you see, along comes myocardial imaging. And this really promises an objective way with which to begin to quantify the minor amplitude and temporal subtleties in motion. So now there'd be some objective parameter to either confirm or dispute our subjective or visual interpretation of wall motion. And so therefore perhaps there'd be less inter-observer variability in the interpretation of function. Now here's a picture of my son and I just a few months ago when we were in Minnesota. And I like to show this picture because I'm of course proud of my boy, but what you can tell is that now my son is bigger than me. My son is definitely stronger than me. And it tells you we've been talking about this for a very long time. And so the objectives this morning are really to provide really what is myocardial imaging, what may be the potential clinical applications, and what may be some of the impediments to its widespread clinical adoption. And as we get started, we need to think to ourselves, how do we obtain in echocardiography velocities of a target? And you see, this, of course, comes from the work of Christian Andreas Doppler that provided us the mathematical relationship between the magnitude of the frequency shift, that is the change in the reflected frequency from the emitted frequency, and the velocity of the target, here's the red blood cell, relative to the source, the transducer. And this is Doppler's frequency shift equation, a common question in the board exam. And you can see that anything in white is really a constant, or it is given to us. And all we need to do then is to rearrange this equation to solve for velocity. Remember that on the denominator of the equation is this cosine of theta, and we heard in the first lecture this morning, of course, that the cosine of 90 degrees is 0, the cosine of 0 is 1. So it's important to stay as parallel as possible to the intercept axis of motion or flow, depending on what you're looking at, so as not to underestimate the velocities. Now, we generally think about this in terms of looking at blood pool Doppler, spectral color Doppler. But in myocardial imaging, of course, we're not looking at the blood cell. We're really trying to look at the velocities of the muscle. And this schematic really illustrates the principles behind Doppler tissue imaging. Where you see here in gray is the high velocity but low intensity signal that comes from the blood pool. And this white bar here represents the high intensity but low velocity signal that comes from the wall. Now, when we're looking at blood pool or blood pool Doppler, this is really considered noise in the signal. So what we need to do is turn the wall filters on. But in Doppler tissue imaging, that's the signal we're interested in. So we need to turn the wall filters off. And now to get rid of what would be considered noise in the signal coming from the blood pool, we simply turn down the gain because it's a lower intensity signal. So in Doppler tissue imaging, we want to turn the wall filters off, and we want to turn down the gains. And here's an example of septal myocardial velocity tracings, where the sample volume here is placed in the base, here is the mid, and red is the apical portion of the septum. we see the systolic velocities towards the apex or transducer. Here we see the early diastolic relaxation velocity, or E prime velocity, and then the late diastolic myocardial velocity associated with atrial contraction, or the A prime velocity. And this can be displayed as well in this curved M-mode format, where we display the distribution of velocities in the various segments over time. So when you see this, what's happened is we've traced the ventricle here from the base all the way around to the other side. So if we want to know what's happening here between points 5 and 6, we come down to this map here between points 5 and 6. Here's the QRS. So in systole, the velocities are red, meaning that they're going towards the apex or transducer. And here we see a velocity blue in early diastole. This is the E prime velocity. And the A prime velocity, the velocity is going away from the apex or transducer. So the goal is to detect regional wall motion. And you can see here that if the sample volume is placed in this segment of the myocardium, these velocities can be displayed in this curved M-mode format as we see here, or graphically as we see below. Now, as we get started, we have to realize that there are different methods with which to obtain a derived parameter, say such as the E prime velocity. We can obtain this using pulse wave tissue Doppler, as we heard earlier this morning already, or we can put the sample volume here and use color tissue Doppler. And in both instances, we can see here the S prime and the E prime and the A prime velocity. But remember that pulse tissue Doppler, or pulse wave Doppler, measures the peak velocities, and color Doppler, of course, measures the mean velocities. So the values that you obtain with pulse wave Doppler are going to be higher than those that are obtained with color Doppler. And this may be important when looking at amplitude parameters, say, for example, using the E over E prime ratio when we talk about diastolic function in this course. You can imagine it's going to be very different whether you use pulse wave or color tissue Doppler. And in the diastolic function guidelines, for example, they're talking about pulse wave Doppler. So remember, pulse wave gives you peak velocities, color gives you mean velocities. The velocities will be higher in pulse wave than they will with a color Doppler. Whether we're talking about blood pool Doppler or Doppler of the myocardium, it's the same principle. So I'm going to show you this two-chamber view, and if you don't mind, use the audience response, because the question is, when you look at this, do you think that you see a wall motion abnormality? So 1, of course, is yes, and 2 would be no. Let's see how this goes. It won't play in the you had to look at it before the questions came up. Okay, so 70, 30, give or take, which is what we'll go back to my slides, which is what I think we would expect, right? Because this is really a somewhat subjective interpretation of whether you think there is or is not a wall motion abnormality. I'm going to show you the same two-chamber view again, but what we've done on the right is that we've traced from the base of the inferior wall to the apex. And on the right here, we've displayed the distribution of velocities from base to apex over time. And now I'm going to ask the same question. Do you think that there is a wall motion abnormality? Right, so now we flipped it around because now we have some objective parameter with which to perhaps confirm or dispute our visual analysis. But the point that I wanted to make here is that there are pitfalls to looking at velocity analysis alone. And these are issues of translational motion or tethering. So in translational motion, if the sample volume here is placed in this basal segment, but the whole heart moves within the chest wall, there's going to be velocity associated with that motion, but it may not represent true compression or contraction. With tethering on the right, the sample volume is placed in this basal but akinetic segment. The mid and apical segments, they contract well. So as they contract, they tug that basal segment with it. There's going to be velocity associated with that motion, but it may not represent, again, true compression or contraction. So to overcome this issue of velocity analysis and the pitfalls, one may look at more local parameters of deformation, things such as strain and strain rate imaging. And strain in mechanical terms is really used to describe deformation of an object, and that is deformation that results from an applied force, this stress-strain relationship. So here we see a spring attached to a weight, and we'll play this animation, and you'll see that as we add an additional weight, the spring deforms more, it gets longer. Add more weights, there's more deformation, strain increases. Take away the stress by removing weight, less deformation, less strain. So again, strain in mechanical terms is used to describe the deformation of an object. And this formula here can be used to define it. So if we have an object of an original length, say it's 10 centimeters, and it gets shorter from 10 to 8 centimeters, then it would be 8 minus 10 over 10, or the value would be minus 20%. If the object got longer from 10 to 12 centimeters, by definition, strain would be positive 20%. And of course, if it didn't change in length, there would be 0% strain. Strain rate, it's a completely different parameter. It is the rate at which these segments either shorten or lengthen. So here, for example, we see the tortoise. It starts at the start line, and the tortoise hits the finish line. The hare does the same thing. They covered the same distance. They had equal strain. It's just that the tortoise moves slower than the hare, so it has a lower strain rate. So you could have a question where they could certainly have equal strain, but very different strain rate. I can drive from Phoenix to LA, and it may take me 5 hours, or Marty in his Lamborghini could get there in 2.5 hours. We covered the same distance. It's just that he went faster than I did. So strain can be equal. The strain rate can be very different. So now when we go back to this apical two-chamber view, the image that we had been sort of working on over the last few moments, and we look on the bottom is this parametric display of strain rate. And the way you interpret this is that anything yellowy orange represents compression or contraction. Anything blue is elongation, and green means nothing is happening. So when that basal inferior wall really is akinetic, there is a wall motion abnormality. It was not depicted or identified in color Doppler because of this concept of tethering, because the mid and apical segments are contracting well, and it's pulling that segment along with it. So we've talked predominantly about Doppler-based techniques. Doppler-based techniques have some limitations to any movement of the myocardium relative to that sample volume, which is fixed in space. If the myocardium moves off that, it's hard to evaluate that. So to overcome this limitation, one can look at Doppler-independent techniques, these sort of feature or speckle tracking, which allows you to look at longitudinal, circumferential, as well as radial parameters of motion. And the principles behind feature or speckle tracking is that the machine identifies a unique acoustic fingerprint of the myocardium, and it tracks those speckle elements really frame by frame. And so this permits the assessment of strain truly in the axis of motion as opposed to the axis of the ultrasound beam. So the advantage of feature or speckle tracking over Doppler is it tends to be less noisy. By principle, it's going to be angle independent. This can be obtained from any standard grayscale image. You can monitor strains in multiple dimensions because there is no fixed sample volume. So it will allow the assessment, say, of rotation or other parameters of motion. And this may be clinically important because we realize that the muscle fibers don't just sort of lengthen and shorten, but that there's this sort of twisting and untwisting. And so if you look at global ventricular function and the relationship between myocardial form and function, you realize here, you see that in systole, the apex of the LV seems to be rotating in one direction. The base is rotating in another direction. It's really causing this ringing effect, literally propelling these spiraling streams of blood through the LVOT and the aortic valve into the systemic circulation. And so the base in systole moves in one direction, the apex would rotate in another direction. The base in systole moves predominantly in a clockwise direction, the base in an anti-clockwise direction, and the difference between these two is the net rotational angle. And if you correct that for the length of the chamber, this gives you the parameter of torsion. So echocardiography is really becoming a very powerful tool that may provide this key to help unlock many of the mysteries to the mechanism of heart failure. And to help shape this key, echocardiography gives us great insights into the morphology of the heart. As we're talking about muscle mechanics, we'll hear more about fluid mechanics and hemodynamics, and this will shape this key to help fit this lock. And so what is evolving now are classification schemes that look at myocardial mechanics. They may help give clues as to the specific etiologic or pathophysiologic mechanism for the ventricular dysfunction. Now, in most progressive myocardial diseases, including ischemic heart disease, it tends to initially affect subendocardial function, that which is responsible for the longitudinal motion of the LV. And this can be identified early on by a reduction in this early diastolic relaxation velocity, or the E prime velocity. Rotational dynamics, which are influenced by the epicardial fibers of the heart, early on may in fact be augmented in an effort here to maintain systolic performance. And it's really not until later in the stages of disease, when you see a reduction in both longitudinal and rotational dynamics, that you begin to see the hemodynamic impact of increase in filling pressure. And clinically, this may be useful. Here we see individuals with the phenotype of heart failure and a preserved ejection fraction. And you see that myocardial imaging can show abnormalities before a global reduction in ejection fraction in these individuals with this phenotype of heart failure preserved ejection fraction. You see here's patients with the clinical syndrome of heart failure preserved ejection fraction. They have a reduction here in blue in both longitudinal and in yellow circumferential strain compared to baseline or controls. If you look in the middle, individuals with hypertensive heart disease, superimpose those with diabetes or other comorbidities which may predispose an individual to HFpEF. You can see that early on there is a reduction in longitudinal, but there's this augmentation of rotational dynamics. And it's really not until you see a reduction in both longitudinal and circumferential rotation that the patients actually slip into the clinical syndrome of heart failure. And that longitudinal strain is also significantly and independently associated with N-terminal proBNP, a prognostically relevant biomarker in this HFpEF syndrome. Surviving cancer, but at a cost. Cardiotoxicity is one of the most important adverse reactions to many chemotherapeutic drugs, particularly anthracyclines. And this cardiotoxicity can occur early, during treatment, or can occur within the first year of therapy, or very late, beyond a year into treatment. And moreover, the changes in cardiac function may be some clinical. And so this whole world of cardio-oncology is evolving. And the difficulty when dealing with the cardiology side effects of these medications is they can often mask themselves as the normal effects from the cancer treatment itself. And it is important, perhaps, for early recognition of this, as perhaps that would influence treatment with early institution of anti-remodeling medications, such as ACE inhibitors, angiotensin receptor blockers, and so forth. So here's a case of a 76-year-old male. He has CMML MDS with associated myeloid sarcoma skin lesions. There's experimental chemotherapy. Here we see the baseline ejection fraction was 66%. 2 months into treatment, the ejection fraction has dropped to 58%. We look here, and we'll talk about this in detail, this global longitudinal peak systolic strain was minus 17.8%, and in 2 months it had dropped to minus 14%. and you see a minor elevation in the troponins. I want to spend a few moments and just take a sidetrack here about what's this parameter, global longitudinal peak systolic strain, because that's probably what they're going to talk about in the board exams, because it's really what we're using most frequently clinically. And if we go and look at this chamber quantification document published in January of this year, what do they say? Well, global longitudinal peak systolic strain in the range of minus 20% for the left ventricle, same as Dr. Rutsky just said for the right ventricle of minus 20%, would be considered normal. You want to optimize image quality, so maximize frame rate and minimize foreshortening. And when regional tracking is suboptimal in more than 2 segments in a single view, the calculation should be avoided. So if you can't see 2 segments, suggest that this should be avoided. This is global longitudinal peak systolic strain. So we need to define peak systole. And for this, we really look at the concept of aortic valve closure. And that's why we often have to begin by looking at this apical 3-chamber view, where we can see the motion of the aortic valve, and we time peak systole to the closure of the aortic valve visually. With Doppler, you can use closure just looking at the closure clicks of the valve. With M mode, if they show you that, it's just when the aortic valve closes. So peak systole is really defined at aortic valve closure. And then you get the various segmental strain. You do the 3-chamber, the 4-chamber, the 2-chamber view, and you can take each of these segments, the values are averaged, to give this global average longitudinal peak systolic strain. So back to this cardio-oncology case, what are evolving now are technologies that allow us to look at things like regional ejection fraction. You can look at longitudinal strain to get some insights into impact of these medications perhaps on patients' cardiac function. So you can look at a patient in October and then a few months later in January, and you can superimpose these parametric displays of function to get a sense of whether there's a decline in ejection fraction or an associated decline in, say, strain or longitudinal strain. And this is important for the early detection and prediction of cardiotoxicity in chemo-treated patients. You can see a reduction in strain of 10% or an elevation in troponin has modest test characteristics to predict future decline in ejection fraction. And although this is a pretty long statement, it's important to review because it states that myocardial strain and troponin, these 2 non-invasive, easily performed measures, recognize subtle myocardial alterations and predict later decline in LVEF in patients receiving anthracyclines and trastuzumab. The negative predictive value of the 2 tests allows the confident exclusion of cardiotoxicity detected by EF 3 months later. So if you don't see a decrease in 10% in their strain or an elevation in troponin, they had about a 3% probability to see a decline in EF 3 months later. In contrast, if either the troponin rised or the strain rose or decreased, they had about a 9-fold increased risk that you're going to see a decline in ejection fraction a number of months later. Here's an expert consensus statement document from the ASE. This was published before the exams were written, so perhaps worthy of us to look at what they had to say, because this is a very sort of emerging field in myocardial imaging. And they talk about cancer-related treatment cardiac dysfunction. If there's a decrease in the EF of greater than 10% to a value of less than 53%. And here in the syllabus, I just put in this, what is defined as reversible, partially reversible, and irreversible for reference. When they talk about global longitudinal strain, they comment it as the optimal parameter of deformation for the early detection of subclinical LV dysfunction. And if you have baseline strain, a relative, not absolute, a relative percent reduction of less than 8% from baseline appears not to be meaningful. Those greater than 15% from baseline are very likely to be abnormal. My son and I were looking at a stress echocardiogram early, or perhaps we can look at things like chamber area change or EF. We can look at parameters of wall deformation, and instead of looking in October and January, we just look at rest and stress. We superimpose these parametric displays of function and get some estimate of whether or not we believe there's truly a wall motion abnormality. So it gives us an objective parameter with which to either confirm or dispute our visual assessment of wall motion and perhaps decrease the intra-observer variability. Here's a common clinical problem in practice, and we're going to talk about this for an entire lecture later in this course. But patients present to the labs and the walls of their left ventricle are thick. And we ask ourselves, well, why would that be? Is it because they have remodeling because they're athletes? Do they have hypertension? Do they have hypertrophic cardiomyopathy? Is it an infiltrative disorder? Is it a storage disease? So here's a patient and the walls are thick. And you're wondering, is this really just hypertension? Because they have a little bit of hypertension, or is this a genetically determined disease, hypertrophic cardiomyopathy? Now, hypertrophic cardiomyopathy, this is a heterogeneous disease resulting from sarcomeric protein mutations, which are characterized by inappropriate hypertrophy of the ventricle. But the myocardial architecture is such that there is disorganized myocardial architecture, this myocyte disarray, there's scarring, there's fibrosis, and the walls look thick. Patients with hypertension, the walls look thick, but they're thick because of some neurohormonal stimulation and hemodynamic stimulation. So the question is, are they really the same? Phenotypically, they look the same. The walls are thick, but the insides are very different, right? So the question is, can myocardial mechanics, the way the wall moves because they're made differently, help us to discriminate whether they have one reason for walls being thick versus another reason for walls being thick? And in fact, the answer is there probably is. And we'll discuss this at some length later in the course, but I introduce you to just this concept of those that have hypertension versus those that have hypertrophic cardiomyopathy, because it really harps on the discussion we had a few moments ago. If you look at patients with hypertension or hypertrophic cardiomyopathy versus controls, at rest the longitudinal strain is decreased. The hypertrophs during exercise were not able to augment strain the same way that the hypertensives were. The hypertrophs, not surprisingly, had more what is defined as dysynchrony because they may have heterogeneity in wall thickness. But look what you see here in many of the clinical trials. You see the hypertrophs' walls are like 26 and the hypertensives are only 18. That's not a very difficult clinical conundrum because you're not going to see too many hypertensive patients that have walls that are 26 millimeters thick. But what was interesting is what we showed earlier. Remember we said that when longitudinal strain is depressed, that rotational or circumferential strain may be augmented in order to maintain systolic performance? And this is exactly what you found. That compared to controls, remember their longitudinal strain was depressed, but circumferential is augmented. And so they have that sort of parameter of function that we were talking about earlier. What myocardial imaging can do is look at the regionality of motion. So in a patient that has apical hypertrophic cardiomyopathy, strain is worse at the apex. If they have the septal variant, strain is worse where the wall is thickness, at the septum. And this pattern recognition may be very helpful. Here's a more recent study really looking at speckle tracking longitudinal strain to help improve the etiologic diagnosis of mild to moderate left ventricular hypertrophy. And here we see they had a similar mean wall thickness. The hypertrophs, you see the strain was lowest where the walls are generally thickest, so there's some heterogeneity in the reduction of strain. The hypertensives, more homogeneous strain pattern. And in the amyloid patients, and I think this is a very likely bullseye that you're going to see on the examinations, and I'll show it to you again and again throughout this course when we talk again tomorrow. But you see in the amyloid patients that the apical strains seem to be well preserved, but the basal strains are depressed. This has been sort of commented as a cherry on top kind of image for the bullseye. And so what we may be looking at these concepts of pattern recognition, looking at changes in myocardial motion that help us to discern what may be the mechanism for the ventricular dysfunction. For example, here's a patient with constrictive pericarditis. Well, constrictive pericarditis is a problem of the pericardium. The pericardium is adjacent, of course, to the epicardial fibers of the heart. Longitudinal function, which is influenced by the endocardial fibers, in constriction tends to be augmented. And in constriction, rotational dynamics tend to be depressed. Perhaps there's inflammation because of the adjacent inflammatory component of the pericardial disease. Contrast this to a patient with amyloid, where you see the opposite, where there's a reduction in longitudinal and more augmentation of rotational dynamics. So it's really this concepts of pattern recognition. LV mechanics in mitral and aortic valve disease. LV dysfunction is frequently subclinical despite a normal ejection fraction. We've talked about that. It may precede the onset of symptoms and portend a poor outcome. And so the advent of these novel imaging techniques has unleashed, as they say, new opportunities for the clinical identification of early abnormalities of LV function. And so we may be looking at new paradigms in terms of timing of intervention in patients with valve disease based on these new parameters of ventricular function, here myocardial imaging. So what really sits before us is truly something unique, something very special. Really a masterpiece in echocardiography, really a shapeshifter in terms of the way we begin to practice. But there still appears to be this fog that oversets this image. And our job is really to sort of wipe away this fog and to really begin to appreciate the true masterpiece that's before us in the world of echocardiography. And one of the main issues, as discussed today as well, is this issue of need for standardization. You see, on the left here, we have, here Image Arena. On the right, we see a feature tracking or speckle tracking from another vendor. There are a number of different vendor-specific proprietary methods with which to acquire parameters of myocardial velocity like global longitudinal peak systolic strain. Here we just see another one. This is Echo Insight from Epsilon Imaging. And the question is, are the values that you obtain by one the same as the values obtained by another? That's clinically very important, because if a patient comes in and is imaged on system A on day one and then 6 months later is imaged on system B, are these interchangeable values? The research literature, if it's obtained on a certain system, is that external validity to your lab if you're using a different vendor-specific system? And we went and we started to look at this. And this is what we found right out of the box, is that if we took the same apical 4-chamber view and we just plugged it in and used this Image Arena versus here Echo Insight, we got very different values in terms of global longitudinal strain. And this really begs to the need for standardization. But this is what we found. We found that the one vendor, the Echo Insight, initially, they were looking at somewhere between the endocardium and epicardial strain, where the other was only looking at the endocardium. So if we took this and we just looked at endocardial strain, the values went from 12.9 to 13.99. One vendor was looking at a natural strain algorithm and the other a Lagrangian strain algorithm. They're different. It's beyond the scope of this discussion. But if we just corrected for that, now we were looking at only endocardium. Lagrangian strain went from 12.9 to 15. One looked at the peak of the average curves and the other looked at the average of the peak curves. If we corrected for that, the value went from 12.9 to 16.17. So now the values, although statistically a little bit different, they were much closer. I just wanted to share with you what the average of the peaks or the peak of the average. So here we see 6 curves, and in the middle there's a little dotted curve which just is the average curve. You could measure the peak of the average curves, or you can average the peaks of all the 6 curves, and you're going to get a different value. So simple things just simply need standardization. Now the values, we said, were still a little bit different, even when we standardized the best we could. And the question of whether this is clinically important or not leads to this concept of scaling or adaptive scaling. The level of resolution is important. So if you looked at this very high resolution image, it's sort of a nonsensical image. It sort of looks like nothing. But at a lower level of resolution, now that image makes a very discrete and identifiable characteristics of this very unique face. Maybe this is the level of resolution we need. Maybe we need slightly higher levels of resolution, and of course, this is still left to some debate and question. And so the American Society of Echocardiography, in association with the European Society and individuals, came with this strain standardization task force, where all these scientists and vendors came in a room for many, many years, duked it out because really no one wanted to play very nicely in the sandbox together, and really said, look, we need to have standardization if this is going to be a commercially viable clinical tool. And what I can say, and this is starting to come out in the literature in these 2015 documents, is that cross-vendor variability now in peak systolic global longitudinal strain may now be less than that of measures of LV ejection fraction. The other issue is that we need to get from here to there seamlessly, right? So any innovation, as I say, in imaging must be paralleled or exceeded by an innovation or workflow, or it won't get adopted because we have limited time and energy and resource to do these things, so it has to parallel innovation and workflow for this to be widespread adopted. A brief comment about 3D strain analysis. No doubt, three-dimensional imaging has been a wonderful advent to echocardiography. It's just that because of issues of lower resolution, both spatial and temporal resolution, 3D imaging, although here to stay for anatomy, it has been a bit disappointing for strain because of it's a little bit less accurate. And so what does the ASC say about this? It remains a promising approach. So as we say, what's next starts soon. The need for standardization, and the ASC has done a wonderful job putting this together. For the widespread clinical adoption, we still need issues of workflow efficiency. I showed you a picture of my son today, and my son a number of years ago looking at the echo. The point is, it doesn't matter how slowly you go, as long as you don't stop. And we're here with the myocardial imaging. So the take-home points here is that Doppler tissue imaging characterizes the low velocity, high intensity signals that come from the wall. Doppler tissue imaging is limited to movement relative to the sample volume, which is fixed in space. Remember the pitfalls of velocity, the translational motion or tethering. That more local parameters of deformation, strain rate, are not influenced by tethering and translational motion. That feature or speckle tracking can evaluate velocity, strain rate from the standard grayscale image. And feature tracking permits the assessment of strain in the axis of movement rather than the axis of the ultrasound beam. I thank you very much for your time and attention. Only 40 minutes.
Okay, we have a couple of questions. Really? Some of which I think you've covered actually already, but we'll... First question is, why on TDI are E' and A' negative?
Oh, because it's going away. It's just if you look at that color scale, right, velocities towards the apex or transducer, it's a longitudinal parameter, and these things are going away from the apex or transducer, so it's negative. S' is positive because it's going towards, and the others are negative because it's going away.
Mm-hmm. Couple here asking what your thoughts are on potential strain-related questions on the boards.
Right, so I think that the potential strain-related questions, I think hopefully we covered most of these things. Some of the pitfalls of velocity, right, that this translational motion, tethering, it's overcome by local parameters of deformation. I think that those 6 points at the end were the main points that I was hoping that you would pick up. We're going to talk about pattern recognition because I really think there's a good chance you're going to see that bullseye with a cherry on top and a thick wall, and it's going to be amyloid and not hypertension, because that's pretty exciting. And I think that if you think about it, the emergence of cardio-oncology as specialty in and of itself, and the use of myocardial imaging as its a fundamental clinical application, that there may be questions, and the ASE came out with a statement last year on that. So I put that in the syllabus, and that's why, because I would imagine that would be good fodder for question.
Can you assess myocardial viability with strain and strain rate?
Good question. The answer to some extent is yes, you can, because you're looking at subtle changes in myocardial motion. There's been a lot of look at myocardial viability using strain and strain rate. But to suffice it to say, I'd be very surprised if those types of questions were asked on the examination, because there are limitations to looking at strain and strain rate as heart rate increases. So if you're using dobutamine stress and so forth, there are some limitations to doing that. And that was all with really color tissue Doppler. So the answer is yes, you can, because you'll be looking for subtle changes. But I would be surprised if those questions came up on the exam.
Then there's a question of the value of RV strain, and I guess the question as well, will RV strain be on the board?
Well, Dr. Rudsky had made a comment at the end about RV strain in just the last lecture, talking about some of the limitations of normal values. If there's a question about right ventricular strain, remember this: it is the 3 segments of the RV free wall, so it's not, that doesn't include the septum. They're just looking at the 3 segments basal mid apical portion of the RV free wall, and a value of less than minus 20%, so more negative than minus 20% would be considered normal. Same value as has been recommended for the LV.
And one very last question, so we don't delay too long. What is the significance of post-systolic shortening on speckle? Can you see it in normals?
Yeah, so post-systolic shortening can be seen in normals. This is this concept of viability and stress and so forth. You can see post-systolic shortening. Remember, though, the parameter that's been most widely adopted, and that which has really been recommended and written in the ASC chamber quantification document, is peak systolic strain. So they're really not talking about post-systolic shortening in this. So again, these concepts of post-systolic shortening, although intellectually very valuable and perhaps clinically useful, I'd be very surprised if those types of questions came up in the exams. But yes, you can see post-systolic shortening in normal individuals.
Thank you so much.
Thank you very much. Thanks.